Hello, everybody, and welcome to today's free webinar presented by Aspire Respiratory Products. This webinar is entitled Head and Neck Lymphedema, an Overview, and will be presented by Lauren Meffen. And Lauren is a speech-language pathologist, a certified lymphedema therapist, and an entrepreneur at heart. She really values her patients and fellow colleagues, desiring to grow their knowledge in our field. She has created resources for families, for caregivers, and for clinicians to improve the evaluation and management of the whole patient. And Lauren has specialized training, teaches nationwide in management of head and neck cancer, trismus intervention, lymphedema management of the head and neck following surgeries and cancer, respiratory muscle training across disciplines, including SLPs, PTs, RTs, and OTs, as well as business development and growth of successful insurance-based private practice. She has successfully developed programs in her community for patients with voice and swallowing disorders while keeping the patient at the center of her promise. And we are so excited to welcome her here today. Thank you for being here, Lauren.
Thank you, Jenny. It sounds exciting. It's amazing what this career can do for us over the years. So that was an awesome introduction. And thank you to Aspire for having me talk about something I'm very excited about.
Easy to give an awesome introduction for an awesome person.
Oh,
And just a little bit of housekeeping in terms of questions, if everybody can just hold their questions till the end, there will be a Q&A session after Lauren's presentation. And Lauren, we are excited and ready to learn from you.
let's do it. So I am excited today to share with you all about a topic that is very dear to my heart. And that topic is related to head and neck lymphedema. And so I want us to think about our patient really as an iceberg. And I'd like for us to think about that we, as therapists, we all want to create a better experience for our patients. We all want to improve our patients' quality of life. But ultimately, the patient who is going through head and neck cancer treatment or has been a survivor of head and neck cancer is really, that's just the tip of the iceberg. And so today we're going to dig a little bit deeper in understanding how we can help these patients navigate this diagnosis, navigate survivorship, and navigate the lifetime side effect that many will call lymphedema. So we know that there are different subsites in our head and neck cancer space. And so I'd like for you to visualize those subsites. And when we receive diagnoses for these patients, each head and neck cancer patient is individualized care. With this individualized care, we are going to, as therapists, explore how can we start to navigate this patient based on where they are in terms of diagnosis, treatment, and survivorship. So let's begin. Head and neck cancer in 2024. Overall, there are around 2 million cases. The oral and the pharyngeal cavity is going to be our leading locations. And so our field loves to help patients who have deficits in the oral cavity or the pharyngeal cavity. In the head and neck cancer world, these deficits can come due to tumor location, and they can come also due to radiation side effects or surgical side effects. Many of our patients will experience other complications that we are going to talk about some today. When we look at the staging of head and neck cancer, we can categorize these patients into 3 different groups. We want to think of these patients whether they have local disease, whether those with local disease have a regional or an advanced disease in which the lymph node may be positive, or are we working with a patient who has a metastatic disease or a recurrent disease? There are many different comorbidities that can affect our patients' treatment, their outcomes, and those comorbidities can also define the long-term risks for our patients who are cured from their disease. So I want you to start to place your patient in terms of, I received this referral. The placement for this is going to be base of tongue. And now I want you to start to think about that clinical case. That patient with the base of tongue disease or base of tongue tumor, does it extend? And did my ENT tell me where does it extend to? Am I going to, in radiation and tumor board, ask those questions to my physicians if I don't know the answer? So staging of head and neck cancer is essential for us to be able to define and outline where our brain starts for our patients' expected outcomes. In this diagnosis, our patients look to us as really cheerleaders, as guiders to say, okay, what's going to happen in week 3 of treatment? What's going to happen at the time of my diagnosis? And why in the world do I need to see a speech therapist? I can talk just fine, right? So staging in head and neck cancer will help us in impacting our patients' clear guidelines, expected treatments, and side effects. The words perineural invasion and lymphovascular invasion, these are locations that we are going to explore in our patients at the time of the referral. If our patient is experiencing perineural invasions, we want to understand the functional changes. So take a moment to pause, ask your patient, and go through what are their baseline sensory deficits. Can your patient feel where you are touching? So if you are going to evaluate your patient and you are going to place different sensory modalities along the cheek or along the neck, offer your patient to say, can you feel that? Sometimes they can feel your pressure, but perhaps they are not able to feel pain in those areas. And in this treatment, that later becomes a very valuable asset for us as clinicians. Because manual therapy in the setting of head and neck lymphedema is incredibly valuable. And in fact, complete decongestive therapy is our gold standard. So if my patient cannot feel me touching the inside of the right buccal cavity, or cannot feel me touching along the right side of the parotid region, or cannot feel me touching somewhere along the right mandible, I need to document that. As a therapist at time of evaluation, I will begin to say, baseline diagnosis, and whatever that is. So my ear, nose, and throat doctors have sent that referral. And then my treatment note or my evaluation note will read, consistent with perineural invasion, findings of decreased sensory and the V3 distribution of the mandible, or wherever that patient's diagnosis is. I want to ensure that my patient presents consistent with the diagnosis. What about lymphovascular invasion? So the challenge in us is that these tumor cells can be transmitted indirectly via the lymphatic system. If our patient has a diagnosis of squamous cell carcinoma, P16 positive, and they are referred to us, and many of these doctors will do an amazing job of referring to us. Sometimes we have to fight for those referrals, but that's what we do best, right? So if our patient is referred to us at the time of diagnosis and they have orders for evaluation to evaluate and treat lymphedema, well, we need to pause for a second. We need to be able to go, okay, our patient has not yet received treatment. Manual lymph drainage is not indicated, as we do not want to contribute to any lymphovascular invasion. So there's a couple of components when it comes to the word lymphovascular invasion that I want you as the therapist to pause. And timing of lymphedema therapy, timing of manual lymph drainage, complete decongestive therapy is essential. We are really looking at helping these patients following treatment of their disease. That is the goal. The bigger the tumor, the greater the concern for metastasis. So in our brains, one of my mentors used to always say, Lauren, the bigger the tumor, the bigger the chance for spread. So I want you, when you see your patient in front of you, if you're looking at a T4 diagnosis, you also need to be looking at the N numbers, which hopefully is an N0, which would mean no nodal involvement, or the M numbers. And hopefully that's also an M0 of no metastatic or distant metastasis of the disease. If my patient does have invasion, if my patient does have extension, this is where I will discuss with my patients based on your primary diagnosis. If you are a T4N1M0, I can begin to anticipate the timing of lymphedema in these patients. So it is very valuable for you as the clinician to understand what does invasion mean and how do I start to navigate that with the patient? Oh my goodness, the cervical lymph nodes. So in head and neck lymphedema, we have superficial lymphatics, we have deep lymphatics. Cervical lymph nodes, to us as a speech pathologist, they correlate and correspond to the TMN atlas. Our doctors will use this to describe the location of the cancer. Our doctors will use these to describe the treatment of the cancer. What's important for us to know is that the lymphatic system is a system. It's a continuous pump, and that pump can be congested. So when you are working with your patients, I want you to break down further levels 1, 2, and 5 into levels 1A, 1B, 2A, 2B, and 5A and 5B. If you don't know the anatomical borders of the levels of the neck, and you are a clinician who is curious or desiring to start to navigate head and neck cancer, this is a great place to start. Understanding the anatomy and where the location of the primary tumor is located or any spread is going to allow you to better understand the treatment zones. If you understand that you have a rim mandibulectomy patient, and that rim mandibulectomy patient is also going to receive radiation to perhaps levels 1A and 1B or 2A, those radiation fields, we now are starting to explore, oh, well, my patient's going to have submental lymphedema or submandibular lymphedema that I can anticipate after radiation. Perhaps they don't present with that initially after surgery, but we can start to anticipate the areas and the pathways in which we want to navigate and explore how that patient's lymphedema will be best managed. All right, we all know this word, HPV, oropharyngeal cancer. HPV tumors are right now one of the most common and widespread STDs in the world. For our patients, the HPV vaccination may or may not have presented itself. We are seeing patients younger and younger with HPV oropharyngeal cancer. I had a 29-year-old in the clinic 2 weeks ago. So if we can anticipate some of these long-term survivorships and outcomes in that patient, then we can help to improve their quality of life. With the vaccination, there are positive impacts on the public, positive impacts in some of the prevention and association of this infection. And so it's important we will know and understand, okay, my patient is presenting to me with an HPV oropharyngeal tumor. What else does that mean? If you've ever sat in tumor ward and looked at HPV histology, or you don't fully understand or navigate, like, why do the doctors care so much if we can get the HPV status? Then part of the reason is that the survivorship for the HPV positive patient, P16 positive at 5 years, is averaging around 68 to 80%. Now, that's phenomenal for our patients' longevity. When we look historically at head and neck cancer survivorship rates in the P16 negative HPV positive population, so if our patient did not have P16, that survivorship was as low as 25 to 40%. So we are seeing these patients younger, they are living longer, and now they have quality of life, late-term side effects of the treatment. In the beginning, I can remember I was sitting in tumor board and I can remember two physicians and they were a little grouchy. And they were like, well, what's the status of the P16? And I just remember thinking I was about 2 years into my head and neck cancer exploration. And I remember thinking like, why do they care so much about that? And then as I started to understand this population more and more and see the patients with HPV positive, I then understood that our HPV positive patients, they're curative. These patients do an amazing job from a disease standpoint in being free of disease in this population. So now it's our role to help improve their quality of life after this debilitating treatment. There are some comparisons and some questions right now as to should we de-escalate our patients' treatment? The survival rates we just discussed about for that HPV positive patient, they're higher. And so there are currently between 2000 and 2022, no randomized studies for that dysphagia optimized radiotherapy. But I want you all to know that this is being explored. When we are looking at dysphagia optimization, IMRT versus standard IMRT, there are some challenges, but there are also some positives. So the challenges include the long-term disease management and the downsides of the IMRT when we're looking at dysphagia optimized IMRT. There are some concerns from our patients in terms of how am I doing 5 years out? We don't yet know. But a couple of things we do know. If our patient receives 50 to 63 grays of radiotherapy or less, somewhere in that realm, they may have better swallow outcomes, especially with sparing those constrictor muscles. Patients who are receiving greater than 60 grays of radiotherapy in a particular field or zone, those patients are more likely to have dysphagia-related side effects, radiation-associated dysphagia, and long-term, late-term side effects. However, interesting to think about, in the group who received the de-escalation for dysphagia optimization, some of those patients did report improved MDADI scores. So something to keep an eye on. Pros and cons to everything in this diagnosis. Tumor locations and tumor sites. Okay, if we have a patient with a tumor in the larynx, choices for treatment. Maybe that patient, if it's a T1 or particular location, is a surgery only. As the tumor becomes larger, the patient may become a surgery, a radiotherapy, and a chemotherapy. There are other locations such as the glottic or supraglottic involvement. And I want you to begin to think about if you have a patient with a hypopharyngeal tumor, it's going to be one of the greatest challenges in terms of that patient with dysphagia-related outcomes. They are going to have the highest level of difficulty often with their swallowing. When we look at the nasopharyngeal cavity, those patients who have a nasopharynx tumor, those patients are going to be patients who have difficulties with the levator veli palatini and elevation of the soft palate. Those patients, after survivorship, after treatment, are fantastic candidates for use of the EMST device. And tumors that are located in the hypopharynx, the oropharynx, we need to navigate those individually based on, again, the sizing, the T3s, the T4s, and we need to take a look at the radiation mapping from our radiation oncologist. Our pharyngeal-related tumors can be, again, located in the oral pharynx, nasopharynx, or hypopharynx. Salivary gland tumors, those are a little bit of a different beast. Our patients with salivary gland tumors are going to have potential long-term side effects related to trismus difficulties, as well as with the oral tumors. Now, how in the world did thyroid tumors make it on here? It's not a head and neck cancer. However, there are some patients who are treated for thyroid tumors. And now they fall on our caseload because we are going to treat them for head and neck lymphedema. Think about the lymphatics and the visualization of where does the lymphedema flow. Those patients end up potentially with fullness, sensations of heaviness following thyroid treatment, and they are free of disease, but they also have symptoms that warrant a referral for lymphedema management. What about the surgeries? Surgeries, we know these: neck dissection surgeries, laryngectomies, glossectomies, mandibulectomies, which is going to be reconstruction of the lower jawbone, versus a maxillectomy, which can also be partial removals or reconstructions of our patient's upper jawbone. Some patients may have resections in the base of the tongue or the floor of the mouth. They may have palatal or labial or lip resections. And we can see composite resections and even transoral laser microsurgeries or transoral robotic surgeries. With each of these surgeries, as speech pathologists, as providers, we can begin to anticipate the course of our patient's expected treatment outcomes. In the neck dissection population, we can review the literature in physical therapy science, and we can find that these patients are going to potentially need long-term help with the spinal accessory nerve. As the surgeon resects and removes the tumor, they may also often have side effects, either at the time of diagnosis or post-surgery, for the spinal accessory nerve. In our glossectomy patients, depending if, let's take a peek. Glossectomy is next. In our laryngectomy patients, here we have two of my patients. And one of my patients hates his Larry tube, and one of my patients loves and utilizes his equipment. In the laryngectomy population, from a lymphedema standpoint, these patients may often present with what we call sort of an apron scar or an ear-to-ear cut. In these patients who have this ear-to-ear cut, the scar tissue from the surgery of the laryngectomy creates a shelf. The shelf allows a collection of lymphatic fluid. The lymphatic fluid doesn't know what to do. It just sits there on the neck. It is our responsibility to separate, remove, and try to work the scars and find a pathway to help these patients better drain their lymphedema. When we look at the approaches for complete decongestive therapy in the laryngectomy population, we are looking at adding compression. We are doing a significant amount of manual therapy, on top of it helping them to manage the Lary supplies. And in our glossectomy patients, maybe we have a partial or a hemiglossectomy, a near total glossectomy, or a total glossectomy. A glossectomy is not a glossectomy is not a glossectomy. And so our surgeons and the surgeon's guide are outcomes. Sometimes our surgeons are able to do a beautiful job in terms of creating flaps and putting together well-constructed tongues that can play as a surface for our patients to be able to communicate at 85 or 90% intelligibility. They can also mash their food. They can puree their foods. Other times, our surgeons may not have a choice, and they are creating spaces where food can be caught in our patients. With every bite, potentially our patient is complaining that they are needing to use a finger sweep or to reach in there and get food out of, a pocket in their tongue. I always try to empower my surgeons the best that I can in sharing and reminding my patients that the surgeon had to get rid of the disease. And so we now have to find ways to live with what we are left with. And that doesn't feel good, it doesn't sound good, and it's very frustrating for our patients. Psychosocial challenges in this diagnosis are well researched. So our responsibility becomes, how can we help our patients navigate a glossectomy, learn their new normal, prevent further some of these kind of fibrotic related changes, versus get them in a daily consistent stretch. Glossectomies post-treatment, when directed and guided by the surgeon, can respond beautifully to manual lymph drainage. What about the maxillectomy? Here on the right-hand side of the photo, you can see our patient's flap in the intraoral buccal wall, versus on the left-hand side, you can see the external edema that is occurring on the left cheek and also pushing up into the left lower eye. And so, I'm sorry, it's pushing up into her right lower eye on the left photo. And so when our patient presents to us with a maxillectomy or a buccal-free flap, we need to evaluate internal and intraoral edema. We also need to evaluate external edema. So how do we start to differentiate this? The words intraoral mean what's inside my patient's mouth, their tongue, their buccal region, their gums, their palate, their floor of their mouth. Internal edema is to not be mixed up with that. Internal edema is what's happening in the pharynx and the larynx, or the pharyngeal and laryngeal regions, that we will navigate and explore post-radiotherapy. So intraoral and internal are two different concepts, but they can get a little bit tricky in terms of terminology. So just try to keep those separate. External lymphedema is swelling that occurs typically post-radiotherapy, usually around that 6 to 12 week mark post-radiotherapy, and external lymphedema is visible. Perhaps we might see postoperative surgical edema, which is different than that of the external lymphedema. So learning our timelines is another trick of management in these patient cases. And then what about the mandibulectomies? Mandibulectomies, again, are individualized treatment. These patients may experience side effects with trapping of food, preparation of bolus. They may experience lingual and tongue edema as the lymphatics are disrupted following radiotherapy in the floor of the mouth, as well as in the buccal regions and the submental and submandibular. We know our patients experience acute complications and side effects. When navigating these patients, the side effects for treatment, we can anticipate are oral mucositis, salivary changes, erythema, edema, and often we may see thrush. We, as lymphedema therapists or treatment of skilled lymphedema management, are not touching a neck that would look like this. We go, okay, this patient is 2 weeks post-radiotherapy. Their skin is healing. When their skin heals, then it is going to be potentially my time. But at this point, we are modifying and staying away from anything that is presenting edematous, erythema, or obviously any open sores. So never hands on the neck when it looks like this. Mucositis guidelines. Okay. Mucositis is one of my least favorite side effects for my patients. It impacts and interrupts their treatment. It will potentially delay their treatment. I just had a patient last week call me and share with me that treatment has been delayed for 4 days, maybe longer, due to mucositis. Mucositis and how we help our patients is challenging. The data is inconsistent, but we think that we can do the following things on that right-hand side with potential considerations for local honey or low laser therapy. There is actually some evidence coming out about it. And our patients want to improve, they want to heal, and they want to move forward in their treatment. In my experience, if mucositis presents itself, that becomes one of the side effects that we need to then manage in terms of compensatory strategies. So mucositis, the good news about it, it's short-lived. We expect it during treatment, and it will then resolve post-treatment. One of my favorite oral care recipes is 1 cup of warm water, 1/4 a teaspoon of baking soda, and 1/8 a teaspoon of salt. Allow those patients to swish around and keep that mouth as clean as possible. There is a correlation between excellent oral hygiene and decreased risks of mucositis. However, some patients are just susceptible to mucositis, whether it's radiation-induced or chemotherapy-induced. Late-term side effects in our patients, I'm going to take a moment just to explore trismus. Trismus is a common complaint and side effect in our head and neck cancer patients. When we have a patient we are working with trismus and we need to get inside their mouth, there are priorities in our brain in which we need to say, okay, trismus intervention first, lymphedema management as best as we can, and then navigate the inside of the oral cavity. We know that late-term side effects will arise. It has been well studied, and trismus is going to be our second highest patient complaint, right behind that of, no shocker, xerostomia. I like to draw for my patients what's happening in their muscles as well as what's happening in their fibers. This particular study looks at the changes that are happening across the saliva with the mucin fibers. It was evaluated prior to radiotherapy and post-radiotherapy. Visually, if we show our patients what's happening to their salivary glands and why they are experiencing dry mouth, they have a better concept of how to cope with it in terms of the long-term side effects. As the fractions of radiotherapy are increased, as little as 25 grays of radiotherapy, the networks of the saliva glands are becoming weaker, degraded, and disrupted. When we educate our patients, we want to ask, and we will be asked, how can I fix my dry mouth? That's one of the hardest questions to answer. When a patient asks me, how can I fix the dry mouth, or when is the dry mouth going to get better? I remind them and start to draw what has happened to their saliva glands so that they better understand why they are not producing saliva and that this is a lifelong side effect. When looking at 723 patients, Sarah Vandergeer and her team, they published an article in terms of the prevalence of trismus intervention. So there's a predictable pattern for our patients with trismus, and that predictable pattern includes tumors located in the maxilla, the mandible, the cheek, the major salivary glands, and the oral pharynx. Those patients, as a note, who have ipsilateral masseter and pterygoid, those patients are going to acquire trismus, not a matter of if, it's a matter of when. Prevention of trismus in patients is not a concept that I want you to get in your mind. We do understand that with daily stretches, we can decrease the risks of trismus, but our patients will need to work at this, and some of them will need to work at this lifelong. Measuring interincisional opening, I complete this quick measurement at each visit. If my patients have teeth, I measure it at the bottom of the right upper incisor, the central incisor, to the bottom of the right lower central incisor. If they do not have teeth, I'm measuring gums, and I'm doing some math for some subtractions of teeth. So lymphatics, let's get into that. Circulatory system is now going to release these large molecules into the interstitial space. That space then begins to try to pick up. The interstitial space is picking up these large proteins, fat, cellular waste, and now we have lymph. Picture the lymphatic system as a rainforest. The rainforest is started by capillaries. The capillaries are then going to try to move the fluid through valveless vessels to pre-collectors and collectors. Eventually, the collectors of the lymphatic system will move it into the trunks. In the head and neck, there are many factors that can disrupt or cause challenges to the lymphatic system, one of them being radiation. Following radiation, the pump of the system is slower and the fluid remains in the patient's neck. That decrease in lymphatic transport is going to impact both the peripheral tissue as well as the lymph flow stasis. Now, when our patient's lymphatic fluid stays in place and it accumulates, that fluid will become hardened, it will become fibrotic if it is not mobilized. So how do we mobilize that fluid? Well, that's where we come in. As manual lymph drainage therapists, as trained in the head and neck world, we can help our patients by anticipating the timelines. So if you recall earlier in the lecture, I discussed the time where lymphedema externally likes to pop up. Remember, there's a difference between external, what I can see, and measure is around 6 weeks to 12 weeks following completion of their radiotherapy. And many referring physicians feel that this is an appropriate timeline to begin to treat your patients with complete decongestive therapy if their skin is allowing it. But I encourage you, if you don't know your physician's team, you are going to start to discuss with them. When can I start to get my hands on your patient? Each doctor will have anticipated guidelines of whether they want you in the mouth, out of the mouth, only on the neck. I am a therapist living in a doctor's world. I do what my doctors guide me to do. If I need to question or ask questions, I do. However, I trust them. So one of the things we know in the lymphatic system is because the head and neck has around 300 lymph nodes, it's a very giving system. It likes to drain. If one region of the head is not draining, perhaps the other lymph nodes will pick it up. Maybe my submandibular will, maybe my cervical. In the lymphatic drainage pathways, the superficial and the deep collectors begin to converge. That conversion are vessels that are moving into trunks. In the body, we have a right trunk and a left trunk that help to drain. And so we are starting to explore the terminology. The supraclavicular region is a favorite region of starting off lymphatic work as well as deep lymphatic stimulation. What about the prevalence of head and neck lymphedema? What do we know? We know that head and neck cancer statistically is only about 3 to 5% of all cancers. Head and neck lymphedema, originally they thought, it's not very prevalent. We're not going to send those patients to those speech pathologists or physical therapists or OTs or massage therapists. It gets better, quote unquote. It doesn't. Studies are beginning to help us. They're beginning to separate what is internal edema, utilizing the revised Patterson scale, measured via endoscopy, whether you're doing a FEES or a fluoroscopic evaluation, ideally a FEES, versus what is external lymphedema, utilizing the MDACC head and neck lymphedema scales or the ALOHA measurements. Now, studies are also starting to navigate these words. What's mixed edema versus chronic edema? So things to consider from a postoperative standpoint is mixed edema is around 69% of our patients versus internal 24% only. Most of our patients are having more of a mixed external and internal lymphatic disruption. If our patient received chemoradiotherapy, we can anticipate that they may experience internal side effects. And with internal side effects and internal swelling comes dysphagia, dysphonia, and a whole lot of speech therapy, manual therapy especially. I don't want you to forget about the quality of life measures as well as the referrals for these patients. Ensure that they are being appropriately referred if they have not already been, especially with mental health and considerations for the financial burdens or changes in these patients' lives. When we look at a typical presentation of the patient who maybe is a P16 positive patient treated with oral pharyngeal definitive chemo and radiotherapy, we're going to anticipate submental, submandibular edema and lymphedema, and we are going to assess that face, the neck, and the oral cavity as well. Versus an internal edema, I can't see it with my eyes. I'm not Spider-Woman. I cannot see it. Or who is it that sees through the X-rays? I can't think of the superhero that does. My kids would be disappointed in me. But the internal lymphedema or internal edema assessment is instrumental. We cannot palpate our patient's neck and say, oh, I think you have internal edema. No, we are objective scientists. We need to look inside their neck. What are those differences between external and internal? And what are those differences between head and neck lymphedema versus the limbs? Well, head and neck is worse with radiation while the limbs are not. Head and neck is worse in the morning. The limbs are worse in the evening. For our patients, head and neck lymphedema can be life-threatening. It is unclear in terms of that functional impact. We're still learning what those lymphatic systems and long-term side effects are. And evaluation in the head and neck, unfortunately, is not fully standardized, but it is utilized and studied worldwide. We know head and neck patients need short-term versus lymphedema. Those patients are for a long time. The compression in the head and neck is only 3 to 4 hours versus in the limbs, it's 18 hours. Our physicians don't like to refer for head and neck lymphedema. They like to say it gets better. But if you have a limb lymphedema, well, automatically you get a CLT referral. So it's our role to bring awareness to our doctors. And there are fewer clinicians who are trained in head and neck lymphedema or are comfortable with it. That's why we hope to inspire you to start this region. If you're not comfortable or you don't know if you can do it, I believe in you, you can do it. What equipment do you need? You need a tape measure, you need a smartphone, you need an iPhone, you need to potentially refer and collaborate from a multidisciplinary standpoint. These patients are not just speech pathologists, they are physical therapists. Head and neck lymphedema is not amendable to volume measurements. So we do need comprehensive photos. We need to be consistent. And we as therapists say, well, I only have 30 minutes or 45. We understand. Ideally, you need 60 to 90 minutes for an evaluation. And the biggest barrier is when we use a tape measure, our tension is off. We understand that there is going to be a relationship between where the disease was, the muscles surrounding the disease, and we want to start to think about where was that tumor? Where was that radiation field? Is there any cranial nerve involvement? And what structures were surgically altered? The facial, masticatory, lingual, pharyngeal, hyoid, palatal, and laryngeal, that's all our world. And each of those have different muscles that are impacted. We want to begin to orient what is happening at the laryngeal region versus the pharyngeal edema, because there are serious challenges with laryngeal swelling, such as airway compromise. And what do we do for our patients who are not responding to traditional MLD? And how can we assess those patients from an internal standpoint? Just a note on steroids, it is temporary. It is not long-term use in these patients. And so we're going to encourage you to utilize the MDACC head and neck stages. If you're not familiar with this, learn to start to touch your patient's neck, learn to feel what's happening in there, what's reversible, what goes up, what goes down, what's hard or clinical for a 1B, and learn the side effects of pitting. In these measurements for our patients, we need to stay consistent. We need to show repeatable progress. We do have human error. We are wanting photographs. We are wanting to take comparisons and reliability. And in the head and neck lymphedema space, there are lots of treatments, tools, and kits. It's not just our hands. Perhaps we are utilizing fibrosis management, scar work, soft tissue mobilization, CDT, such as enhancements. I love elastic taping. There's a lot of science that's starting to navigate on the compression pump. And so this is part of our patient's world. If you are not trained in manual lymphatic drainage, get trained. there's contraindications. We are skilled clinicians. We can follow those contraindications, and we can understand that complete decongestive therapy is going to make a difference in our patient's life. Your patient will benefit from you. They will benefit from your hands and from your touch. Compression. This is me in my scary compression mask that I do put on for my patients to help them better understand that they are not alone. This is a clinical decision-making process, and our patients do respond well to head and neck lymphedema for a home treatment program. It is effective and it is proven. We can teach our patients and our caregivers. So I encourage you to start to navigate this territory, and thank you for listening to me. I am happy to open any questions up for you all now. I'm going to end my screen share, Jenny.
Thank you so much, Lauren. That was very informative, and I bet a lot of people are feeling inspired. So the floor is open to questions. You can either type your questions in the chat or in the Q&A, or raise a hand if you'd like to try be allowed to speak. Okay. Let's see.
I see a hand raised.
Yeah. Amanda, did you want to speak? You're muted still, so you can unmute yourself.
I didn't mean to hit the button. I'm sorry.
That's quite all right.
Okay, Amanda, we're still here if something comes to mind.
Thank you.
Sure. Okay. Let's see. We do have a question in the Q&A. Is there a way to get the slides to us with our patients? We don't generally send out the slides, Casey, but we do offer this presentation on demand. So this will be accessible to you to review at any time, and it'll be up on our YouTube channel, which is Aspire Products Education. And Mary, yep.
Mary asked that same thing. Can we get a copies of your presentation? And so that same question. And I would encourage you guys too, Jenny, if I can add to that, if they're wanting to learn more, like there's some phenomenal schools right now working with head and neck lymphedema. So start to navigate those courses. Just take one and then explore more.
Yeah, absolutely. And Lauren, can you talk a little bit more about your site where you share a lot of information?
Yeah, so head and neck rehab is my mission is to help our patients. And through helping our patients, I'm helping the therapist. So we are offering resources for you all in which you can continue to follow us as you create more. And also, if you email me and say, hey, I'm a therapist, then I'm trained in this and I'm learning to navigate this, will you share with me a resource? Many times I have already created a resource, no reason to reinvent the wheel, and I will share.
And Lauren, what is the best email to reach you?
Lauren@myrehabworks.com.
Okay, I'm going to put that in the chat for everyone. And in the meanwhile, Chelsea is asking, would you mind briefly summarizing the treatment difference in therapy of internal versus external lymphedema?
Oh, yes. So Chelsea, external lymphedema is going to be treated right now through our complete decongestive therapy, manual touch, compression, skincare, exercises, versus internal lymphedema is going to be now studied. We know how to evaluate it. We know how to look at this, but the studies are just coming out about manual therapy for internal edema. And so I would encourage you to continue to follow the science and the literature on internal edema treatments, because literally in 2024, they're starting to get published.
Perfect. And do you have, Lauren, any suggestions for where to get certified specifically for SLPs?
Yeah, so I personally love the Norton. As a disclaimer, I do teach for Norton, so you guys are stuck with me if you decide to take that. I also have a wonderful colleague, Lori, who teaches other times with Norton. So in the head and neck space, I want you to not think of this as a certification. I want you to think of it as a training. So initially, to be able to treat these patients with head and neck cancer and lymphedema, we understand that you know the anatomy and physiology, and so there are exceptions to begin. But I also think that there are some fantastic options in terms of close, chow. I have some colleagues who are working with ACLs as well. So I say just start where that journey fits in your life.
That's an excellent answer and good advice. As someone else is asking, this person is an SLP considering manual therapy versus CLT. She works in an ENT clinic. Which do you recommend starting with?
Manual therapy. So if I would encourage, that's where I started. So I started manual, and then later I kept going, well, I want to learn more. And so then I explored the CLT venture, but I encourage manual.
That was a very confident answer.
Yes.
Good. And okay, internal lymphedema. Can we talk more about how to address this? What about the
Yes.
pumps?
I'm going to encourage you to follow the science of Jessica Gregory coming out in terms of the pumps. We are starting to explore that in our speech pathology world. And so I have a lot of pros and a lot of cons on the pumps. I do believe, in my personal opinion, that we want our patients to fail traditional therapy, and then we want to explore and navigate what does that look like. But the pumps can be incredibly valuable in the right patient who can't do their own lymphatic drainage or need some additional support, especially when having trouble with bringing their hands up to their neck.
Perfect. And I think you recommended some courses for us. So that question is answered. Do you have
Yes.
any recommendations of courses for hands-on MLD training near San Francisco?
Oh, Lori is teaching one in California. Now, I don't know geography well. My 12-year-old would kick my butt. But if you look up a course on Norton head and neck lymphedema management, my colleague is teaching one in August in California.
Perfect. And Lauren, can you talk a little about how you use swallowing under compression?
I use my favorite device, expiratory muscle strength training under compression. My patient puts their compression on, they take a breath, and they blow into their device because we know that exercise and activation is needed for pharyngeal constriction as well as suprahyoids under compression. So we do believe in exercise with compression.
Interesting. Okay. And from Claire, we have, my concern with waiting for that long to initiate treatment is the laying down of fibrosis. Can you speak to the recovery cycles, inflammation, proliferation, etc., and how our manual therapy will fall in that timeline?
Absolutely. So I want you thinking of it as that your patient is coming to you at different stages. If your patient's etiology and diagnosis, are we putting our hands on for manual therapy for pain management versus our patient is treated, they are free of disease or no evidence of disease? We understand that the fibrosis processes are kicking in around the 3-month post treatment standpoint. So if we study the science between healing and tissue healing of fibrosis, we can expect 3 months to 12 months is where the fibrosis is kicking in the most. And so we have about that 3 to 6 month window where we like to rehabilitate and improve those patients' lives as best as we can post-treatment. So I encourage my patients to really come to me during that time.
Yeah. And Lauren, how can you tell by looking at a patient that it is lymphedema versus just body habitus?
That's a good question. Okay, so lymphedema we are talking about today is secondary lymphedema. Secondary lymphedema is secondary to radiation side effects. So our patient has a diagnosis, a primary diagnosis of head and neck cancer in this setting. They were treated with definitive chemoradiotherapy or surgery, and we have anticipated side effects of lymphedema. We take pre and post measurements, pre and post photos. So we have expected guidelines of what's going to happen to that lymphatic system when we study it well.
Okay, and have you ever found when addressing internal lymphedema with manual therapy that it worsens their lymphedema?
I have found that internal edema will worsen with time, not to be mixed up with I am going to make things worse. Internal edema is a long-term game. And we are finding that these patients may have lifelong side effects from internal edema, or even up to 2 years. When their external lymphedema disappears, the internal edema is still presenting. That's why it's so essential to gain baseline data measurements via endoscopy, as well as follow-ups via endoscopy around that 12-week mark post-treatment, and then continue to follow those guidelines. But there is science suggesting that the internal edema can worsen with time.
Perfect. I'll give you one more, Lauren, and then if you don't mind, we'll put up that last slide again with the link. But the last question we'll take is regarding the timeline of our services. When is it appropriate to initiate RMST? For example, before radiation, during, after?
Yeah, so we like to think of these patients as an individualized care. So RMST can be beneficial depending on the reason and depending on the time of diagnosis. So if our patient is a surgical patient immediately postoperatively, that's not an RMST patient. If our patient is an HPV positive oropharyngeal tumor 3 months post-treatment, that patient is a fantastic RMST patient. So we know that we are fighting radiation-associated dysphagia in these patients. In reviewing that, Dr. Hutchison had a great lecture that she gave for you all on the Aspire website. And so we are fighting that, and those guidelines from her science and her literature help us to determine what to do for these patients.
Thank you, Lauren. And that Kate Hutchinson webinar is available on our website. I did post the link to our YouTube channel in the chat, and Lauren is going to share her final slide with those links.
And thank you so much, Aspire, and thank you so much for you all. You guys are
Lauren, for
awesome.
being here. Thank you for these questions. If we did not answer your question, you can feel free to reach out to us or reach out to Lauren. We would love to connect with you. We will be having another webinar or several other webinars coming up in the next few months, and you can find the information for those at emst150.com/events. We would love to see you all there. Thank you. And as always, we are happy to support you. If you need anything, feel free to reach out. Have a good evening, everybody. Thank you again, Lauren. You were wonderful.
Hi, guys. Go do amazing things.